Welcome back, friends, to another edition of Psych with Arjun. As with our other videos, we here at First Aid Express like to ask questions, and it's not because we like to hear ourselves talk. Even though you could wait the 1 or 2 seconds it takes to hear the answer, I strongly encourage you to try to come up with the answers on your own. It'll help keep you engaged and give you sort of an idea of how well you actually remember some of this stuff. This episode, we're going to venture into the world of psychiatric pathology, so y'all better get excited. I'm going to start off with the effects of infant deprivation, but first, I want to talk a little bit about the strategy for the psych section. In the DSM-5, there's a bunch of extremely extensive, specific criteria that distinguish the pathologic patients from the ones that are just a little bit quirky. On step 1, however, it'll only really behoove you to memorize specific criteria for a handful of the most commonly tested diseases. And even then, remember that this isn't the real world. It's often not necessary or time efficient to run through the full list of clinical criteria for each vignette. Rather, it's more efficient to use what emergency physicians refer to as your gestalt, to approximate which disorder it could be. Then, you can use your awesome test-taking skills to start eliminating answer choices based on your general observations. The most important part of Step 1 psychology, in my opinion, is mastering the distinctions that allow you to distinguish between similar disorders, and to understand the differences in treating said disorders. And that's exactly what I'm going to be focusing on today. I trust a group of bright individuals such as yourselves can memorize SIGI caps on your own time. That being said, what separates a good score from a great one is knowing all the trivial details, so for you high rollers out there, I do recommend you spend some quality time with the first aid mnemonics. But that's not something I can exactly read to you, kind of got to flashcard that on your own. So for now, let's get started with the highest yield stuff, starting with child psychology. They say there's nothing as strong as a mother's love, at least if you believe Harry Potter. Turns out an affectionate infant-caregiver bond isn't just great at preventing lethal curses, it's also essential at proper development. Infants who are deprived of affectionate care can end up weak, wordless, wary, and wanting, or socially wanting, that is. More specifically, they have failure to thrive, which is a PEDS term that means they're either severely underweight or don't grow normally. They have poor language skills, presumably because no one talks to them. They have a hard time trusting others and develop poor social skills, which again, makes a lot of sense. In fact, if they have literally no caregiver for the first 6 months of their lives, the psychological consequences will likely be permanent. Now, the really horrible thing that happens, though, is something called anaclitic depression. And I'm not talking, ooh, baby's so sad, look at him crying. Babies are supposed to cry. No, these babies are so miserable that they stop responding to external stimuli, become comatose, and die. Literally, babies die from nobody loving them. Have you seriously heard anything sadder than that? That's like Sarah McLachlan level sad, with the puppy video. Now, because I like to keep y'all uplifted during your Step 1 study period, let's talk about child abuse. It's traditionally divided up into physical abuse and sexual abuse, with neglect sometimes being considered a part of this category. Physical abuse in particular is responsible for about 40% of infant deaths under 1 year old. Now, what kind of person abuses kids, you may be asking yourself? It's usually one of the caregivers. And while everybody immediately jumps on the stepfather or the boyfriend, some research shows that physical abuse is more likely to be inflicted by the mother, if only because mothers, on average, spend more time with their kids. Now, kids can be pretty dumb and do hurt themselves a lot, but your job on Step 1 will be to determine whether the kid's injuries are actually suspicious of child abuse. The first question you should ask yourself is, does the story match the injury? A perfectly circular, oddly cigarette-shaped burn doesn't just get there by accident. The next question you should ask is, does the story fit the kid's stage of development? Now you can use your common sense here and realize that really young babies can barely move, much less do anything that causes themselves some serious injury. Second, some injuries are just straight up suspicious for inflicted trauma, especially in infants. Can you think of any examples? Cigarette burns are probably the most immediately recognizable sign of inflicted abuse, and burns with clearly demarcated lines should raise red flags for the most common type of burn in physical abuse cases, the immersion burn. Spiral fractures is another common buzzword that you hear in relation to physical abuse, but what actually causes a spiral fracture? It's actually pretty intuitive. Spiral fractures involve long bones, most often the humerus, when the arm is grabbed and twisted. If you see multiple fractures in different stages of healing, that's extremely supportive of abuse over a long period of time. One of the most tragic and highly tested constellations of physical signs is shaken baby syndrome. Never shake your baby was a highly circulated PSA at one point, which totally blows my mind because what do you really expect is going to happen when you forcefully shake something with a huge head, a weak neck, and a developing brain? As it turns out, a lot of things. First of all, bruises around the trunk or posterior rib fractures may be seen from where the baby was grabbed forcefully. You can see how the ribs have calloused after being broken here and here. Second, there may be significant cervical spine injury from the force of the baby's large head moving around on its weak neck. Finally, and often most characteristically, CNS bleeds like retinal hemorrhage or detachment and subdural hematomas occur because of the shearing forces of the brain moving around in the skull. Now, how can you tell a subdural hematoma wasn't just caused by accidentally dropping the baby? Because any other kind of trauma that causes an SDH will at least leave a mark on the kid's noggin. Shaken babies characteristically have subdurals without signs of external trauma. Sexual abuse, unlike physical abuse, isn't usually committed by the caregivers, which I guess gives me just a little bit more faith in humanity. But like adult rape, the abuser is usually someone the child knows, and is usually male. You should suspect sexual abuse if the child exhibits what is known as sexual precocity. What counts as being sexually precocious? That's a great question, and that's one that's really important to know for step one. Know that it's totally normal for kids to experience body curiosity, or even masturbate, but when they start doing stuff like foreplay behavior or know stuff about sex that they really shouldn't, that's worth investigating. Sexual abuse tends to happen when kids are older compared to serious physical abuse, and I'm sure you can guess what the physical signs generally involve. Couldn't bring myself to look up pictures for those, so if you want them, you're going to have to find them yourself. So, I promised you the differential diagnosis, and I definitely intend to deliver. With child abuse, the official stance in the real world is that if you suspect it, you should report it. On step one, however, there are several instances in which they'll want you to stop and think before you go and call CPS. There may be a completely legitimate explanation for something that looks like child abuse. So I told you that multiple fractures in different stages of healing is pretty suspicious for ongoing abuse. But what if I told you that the kid and his mother kept coming to the ER with multiple fractures from, quote-unquote, tripping and falling? Okay, that's a bad example, I guess. What if I told you that both of their eyes actually look like this? This is most likely to be osteogenesis imperfecta, an autosomal dominant disorder that results in fragile bones, but can be distinguished from abuse by blue sclera, heredity, opalescent teeth, and hearing loss. While we're on heritable disorders, what about a kid who keeps coming in bruised from trauma that you're pretty sure shouldn't cause this level of bruising? While this is pretty suspicious, you should go ahead and order yourself a quick and easy coag panel. Prothrombin time, partial thromboplastin time, and bleed time to make sure that the patient doesn't actually have a bleeding diathesis like hemophilia or von Willebrand's disease. These are also distinguished from abuse by their heredity, though they may have patterns of abuse that for normal people don't make sense with the stories they provide. I'm just going to touch quickly on child neglect because there's only a few things you really need to know about it for step one. Child neglect is the most common form of child maltreatment, but unfortunately the consequences can be just as serious depending on the extent of the neglect. As we talked about with infant deprivation, even a lack of social attention can cause a young enough child to fail to thrive and become completely unresponsive. Malnutrition and poor hygiene, as you can see in this picture, are common signs of severe neglect. What you really need to know about this is that it requires the same severity of response as child abuse. If anything from the history and physical exam tells you that the kid's being neglected, you need to act quickly and call CPS. Wow, is anyone else a little bit more depressed by the end of this? I know I am. Let's do a flash quiz and wrap this section up for good. Alright, I'll keep this one pretty basic. Retinal hemorrhages, cervical spine injury, and posterior rib fractures are evidence of what mechanism of child abuse? And the answer is shaken baby syndrome. Well done, everybody, and now let's move on to the childhood psychiatric disorders. ADHD is one of those disorders that has a bunch of really specific criteria, but let's be real. We all know what ADHD is about. It involves a short attention span, hyperactivity, and/or impulsivity, and really, that's about all you need to know for step one. There's a few other things that are commonly a part of the vignettes. It starts before age 12, they're disruptive in class, they get poor grades but aren't retarded, and finally, they're usually okay when interacting with someone one-on-one, but you can generally recognize the symptoms of ADHD right off the bat. You can treat or supplement treatment with cognitive behavioral therapy, but the mainstay of treatment is pharmacologic, specifically stimulants. Most of these, like methylphenidate, dextroamphetamine, and even methamphetamine, are amphetamine derivatives, but there's the thought that pretty much any stimulant will do the trick. In fact, while 50% of ADHD sufferers are thought to quote-unquote outgrow their ADHD, there's the thought that many of them are actually just unintentionally self-medicating. And if you had to guess, what stimulant do you think we're all taking to suppress our ADHD tendencies? But stimulants, as any caffeine junkie will tell you, are habit-forming. And the amphetamines have a large black market that one or more of you listeners may be all too familiar with. This is where atomoxetine comes in. It's the only non-stimulating, non-habit-forming medication approved for ADHD. Does it work as well? No. But as we'll talk about, ADHD is associated with a number of disruptive behavior disorders, and let's just say it might not be such a good idea to hand some of these kids easily divertible addictive drugs. One of these disorders is called oppositional defiant disorder, where kids are routinely hostile, angry, and defiant towards authority figures. The really bad kids are said to have conduct disorder, where they aren't just defiant, but actually seriously violate the rights of others. These are the ones that start fires, steal, and are perpetually violent. Does this sound like any adult disorder to you, by the way? While they have slightly different criteria, conduct disorder is basically just antisocial personality disorder in anyone younger than 18. In fact, without intervention, many of these kids actually do end up developing ASPD. The treatment for both of these is cognitive behavioral therapy, and while many of them have ADHD, remember that atomoxetine may actually be the best drug since we may not be able to trust them with the amphetamines. When it comes to differentiating ADHD from ODD and conduct disorder, remember that while all of them may show symptoms of ADHD, they differ in how disruptive they can be. ADHD patients can be disruptive, but are generally good kids that can't sit still. ODD patients are rebellious and are actually kind of jerks a lot of the time. Finally, conduct disorder kids are pretty much criminals, or will be once they get caught. The last two childhood onset disorders that you need to know are separation anxiety disorder and Tourette's syndrome. Separation anxiety is exactly what you'd think it is. And you may see a scenario on step 1 where a kid's brought in by their parents for some generic complaint that their kid has that, oh, by the way, happens to be around the time that they're supposed to go to school. This is also best treated with therapy, specifically CBT, play therapy, or family therapy. The differential diagnosis for this one's actually pretty broad and includes various other types of anxiety disorders, including adjustment disorder and social phobia. We'll talk a little bit more about those when we get to this section on anxiety spectrum. Tourette's syndrome, along with ADHD, is everyone's favorite disorder to pretend they have. Quick, what's one word that describes Tourette's syndrome? If you said a swear, particularly one regarding excrement of the anterior or posterior variety, then congratulations. You just described about 10 to 20% of all actual Tourette's patients. Shame on you. Tourette's involves both vocal and motor tics that often change a lot throughout a person's life. The compulsive swearing part is called coprolalia, which, you may be interested to hear, is Greek for poo-poo talk. Don't believe me? Ask Dr. Wikipedia. Most cases just require reassurance or therapy, and almost all kids grow out of it. If it gets way too disruptive, you can use low doses of a high-potency antipsychotic like fluphenazine, or an alpha-2 blocker like clonidine. One high-yield fact that seems to come up a lot is that Tourette's syndrome is associated with obsessive-compulsive disorder. It's also associated with ADHD, but OCD is the one I see tested the vast majority of the time. The previous childhood disorders are considered childhood onset, but may resolve in adulthood with treatment. The pervasive developmental disorders, on the other hand, are for life. In the DSM-4, there were a whole bunch of pervasive developmental disorders, including autistic disorder, Asperger's disorder, childhood disintegrative disorder, and Rett syndrome. In the DSM-5, there's only one category of disorder, and it's called the autism spectrum. It's characterized by the degree of social and communication disability and fixated or repetitive behavior. Now, these are the central features involved in all autistic spectrum disorders, but each autism spectrum individual may have associated features, like mental retardation, sensory overload, or savant skills. By the way, even though the last one is everyone's favorite type of autistic, this is super uncommon. Just like Tourette's syndrome and coprolalia, savant skills are actually not that representative of autistic individuals. I suppose this is as good a time as any to address the question, does the USMLE use DSM-4 or DSM-5 criteria? As in, do I need to know about Asperger's versus autism, etc.? Fair question. The DSM-5 was only released in 2013, and Step 1 is known for being at least a couple years behind the curve. But this represents such a radical change in the entire field of psychiatry that the USMLE has actually removed all questions that involve DSM-4 terminology that's been eliminated from the DSM-5. So no, you don't have to know the difference between autism and Asperger's. The only disorder in the autism spectrum that you'll specifically need to care about is Rett syndrome, and that's because the etiology is unique. Now, does anybody know why autism happens? Well, other than vaccines, of course, which we're informed about from reliable sources, we don't have much of an idea. Rett syndrome is pretty much the only autism spectrum disorder that has a known etiology. It's an X-linked recessive condition found only in girls. Wait, what? An X-linked disorder found only in girls? Well, you heard me, friendo. Turns out, the only way to survive the gene mutation that causes Rett syndrome is by having a normal copy of the X chromosome as well, which kind of excludes boys. Girls can survive the heterozygous mutation, but end up a little different. Boys and homozygous girls, on the other hand, die in utero. The disorder involves classic features of the autism spectrum, with hand-wringing being the most characteristic repetitive behavior. Other than that, it does involve mental retardation and ataxia, and is actually pretty unique in the autism spectrum for causing a regression of verbal abilities. Most autism spectrum kids actually never have them to begin with. By the way, this isn't really classified as a pervasive developmental disorder, but can you think of any other genetic disorder that tends to co-occur with autism? Think back to biochem. This one's also found on the X chromosome. The disorder is Fragile X syndrome, which, as you may remember, is a trinucleotide repeat mutation making it X-linked dominant. So as a weird coincidence, both Fragile X and Rett syndrome are X-linked mutations that can occur in females. Spooky. So why isn't Fragile X considered an autism spectrum disorder? Well, because autism isn't one of its main features. In fact, depending on the study you read, only about half of Fragile X patients have autism spectrum features. The disorder is also notably associated with ADHD. And for more information about the defining characteristics, you gotta check out the biochem section. Alright, no way. Why the heck did Arjun just put hearing loss in with the developmental disorders? Because it's super, super important not to confuse hearing loss for other childhood disorders, such as ADHD, mental retardation, or even autism. Deaf children may be fully able to understand families by reading lips or other compensatory techniques, but if they're spoken to when they're not looking, they may not turn around and respond. See how easy that can be confused for an ADHD kid spacing out? Or an autistic kid's inability to socialize? These vignettes that try to confuse deafness for a mental disability will almost always hint at that difference. For example, stating that the kid is always responsive at home when you're looking straight at him. If it's an option, order a hearing test just to make sure, because hearing loss can lead to progressive language deficits that are totally preventable, just by correcting the hearing problem. Alright guys, we're done with the childhood disorders. Now here's a flash quiz to keep you all on your toes. Name 2 disorders that are associated with comorbid ADHD. Go ahead, pause the video if you need some time to think. And there are actually 3 possible answer choices: oppositional defiant disorder, conduct disorder, and Tourette syndrome. ODD and its cousin conduct disorder are highly comorbid with ADHD, while Tourette syndrome is associated with ADHD, but it's actually the association with OCD that's more frequently tested. Now we're going to take a different path and explore that weird gray zone between neurology and psychiatry. Relax, I'll guide you through it.